So the first thing that comes up and comes up really regularly is the theme around the mental and cognitive symptoms of menopause. And that's quite shocking for a lot of women because they've been led to believe that it's hot flushes and periods stopping. So I wondered, Nick, one of the questions we get asked all the time is, why do those things happen? What's the connection between estrogen and the brain? And I wondered if you would be kind enough to talk to us about the importance for estrogen and the brain and what's really going on there and why those symptoms are so prevalent in so many perimenopausal women.
I think that's a really interesting issue, Diane. And it's one which I'm often seeing ladies about because perhaps the symptoms don't present in the classic way of hot flushes and sweats. But I think you'll agree with me that often the mental health symptoms, the emotional symptoms, are in many ways more distressing than the hot flushes and sweats, and interfere with a woman's ability to function personally, socially, and professionally. And often these symptoms appear to go hand in hand with sort of cognitive problems as well. So as well as fluctuating moods or low mood, there's often brain fog as well, which makes it difficult to function up to one's normal level. So the reason this occurs, we believe, we think it's genetic. We think that women who are particularly affected by symptoms, particularly these type of symptoms, have a genetic preponderance or vulnerability to be affected by fluctuating hormone levels, which affects their neurotransmitters. And the particularly important neurotransmitters are serotonin. So as estrogen levels start to fall, serotonin levels start to fall or fluctuate, and that can lead to low mood, it can lead to anxiety, depression, but also, and I find that this often goes hand in hand, the women with cycle-related symptoms seem to react adversely to rising progesterone levels in the second half of the cycle, which increases GABA levels, which then has a central nervous system mood lowering effect, a depressant effect. So not only do I find that as estrogen levels fall in the approach to the menopause transition, but those women that are, if you like, genetically more vulnerable to hormone fluctuations that lead to PMS, those PMS symptoms, or in severest form, PMDD, also seem to occur. So you get this sort of perfect storm of cycle-related symptoms and falling estrogen levels, which leads falling serotonin levels and low mood. And we believe that it's this combination of factors that makes it very difficult, and indeed, I would say in some instances inappropriate, to just throw antidepressants at the picture, at the situation, and why these women often do better with hormone therapy, particularly moderately high doses of estrogen delivered through the skin, and where there is progesterone intolerance, either delivering the progesterone vaginally or using reduced courses of that. And I find that by stabilizing those hormonal fluctuations, you stabilize the neurotransmitters, and therefore that has an uplifting effect on mental health, a mood elevating effect. Now, there are data from trials showing that estrogen at these moderately high doses, typically 100 microgram patches or 4 pumps of estrogel per day, can have benefit for these symptoms. But we definitely need more research. And I think we particularly need more research to understand why some women are more affected than others. But there's some really interesting work that Peter Schmidt and David Rubinow have been doing, professors at the were at Harvard when they did this research, showing that the hormone receptors in women who are vulnerable to these changes, particularly the estrogen receptor, are coded differently genetically to those women that don't have these vulnerabilities to hormonal fluctuations.
It's
So
really interesting. Nick, how, this is not a question that, kind of we had discussed before, but, sort of off the top of your head, the women that you would see in all the settings where you practice, kind of percentage wise, how often do you think you would, I know that you're generally seeing women who are, sort of probably in the 1 in 4 who are having debilitating symptoms. How often do you think you see these, kind of psychological and cognitive symptoms percentage wise?
I think it's one of those questions that if you don't ask, then you don't necessarily get volunteered the information. Okay. But in my practice, I would say over 50% have these emotional and cognitive symptoms if you ask about them. And I would say that in the majority of those that do have them, they find those symptoms at times even more distressing than the physical symptoms and the classic symptoms like hot flushes and sweats.
Yeah, the reason that I ask is because the majority of the women that I counsel, those will be, kind of, they're a sort of, when you ask them, they're their top symptoms. And again, we have to take into account that those women are coming along because they are struggling. They're not the women who are not experiencing symptoms. So we are looking, a specific cohort here. But it's just really interesting, isn't it, that there is still this sort of public perception that menopause is hot flushes and period stopping, when in fact for many people it is the cognitive and psychological symptoms which are the most debilitating and have a significant effect on their quality of life.
One of my colleagues that I trained with, Professor John Studd, always used to talk about the triad of hormone-responsive depressive disorders. So this is, premenstrual symptoms, that then that individual is usually well during pregnancy because hormone levels after the first few weeks are high and stable, and then postnatal depression or postnatal blues. And then as the menopause approaches, perimenopausal depression, all in the same predisposed individual. And I think that model, still stands true today, that we believe is a very good way of ascertaining whether somebody has that hormonal vulnerability, if you like, but they were well until their period started. They may have had a really bad time also as adolescents, because we know that that's another time when hormone levels fluctuate. And I see, sort of young women in my practice who are really struggling at school. And then once you stabilize the hormones, either using the pill or hormone therapy, they do so much better. And then, listening to how they were in the latter half of pregnancy when they're usually well, unless they've got sort of ongoing morning sickness. And then the sort of blues postnatally, as the placenta separates and you get loss of those hormones of estrogen, progesterone. And so in those women in whom we were using hormone therapy, for instance, with premature ovarian insufficiency, we were replacing hormones, and then they went on to have perhaps egg donation and a pregnancy there. It's really important to get those hormones back in early. Or the women that we're treating with PMS that are well during pregnancy, again, really important to get back in with those hormones as early as possible. And we can use the hormones during breastfeeding as well. Once the breast milk has come down, there's no reason why that can't be given, no harm to the baby, as long as we use the bioidentical type hormones.
Yeah, I mean, I remember reading the paper that you and Professor Studd wrote, Nick, about, sort of about postnatal depression and hormones, and the connection there. What's your thought about, not specifically around those women who have experienced PMS or POI in the past, but women more generally? What's your thought about, kind of the drop in estrogen when the baby has been delivered, and about whether or not there should be a conversation around estrogen being more widely available to those women?
Well, this is where we need better collaboration between gynecologists, obstetricians, psychiatrists, and psychologists.
Yeah.
Because I believe that this is an area that isn't given sufficient attention. And these women often do end up on antidepressants, and hormones aren't considered. And there was a very good study performed by Alain Gregoire with collaboration from Professor Studd, Professor Kumar at King's many years ago now, that really needs to be replicated. And that study showed clearly the benefits of postnatal use of estrogen to treat depressive symptoms. But until we start to do research again within that area and get licensed options, I think and use of psychoactive medications is going to predominate. I'm not saying that estrogen is the complete answer.
No.
But it should be part of the armamentarium.
It should be a consideration.
That we use.
Yeah.
Absolutely.
And Nick, when we're talking about this kind of paucity of research or the lack of research, are we talking about just the finances being available for that?
It's partly financial. I think also it's partly because of the lack of collaboration between gynecologists and psychiatrists.
Yeah.
And I work closely with Michael Craig, who runs the psychoendocrine clinic at the Maudsley, which is a fairly unique clinic.
Yeah.
And Michael describes himself as a gynecologist because he also sort of qualified in gynecology as well. But we need more people like Michael to collaborate with.
Yeah.
I'm going to keep working with Michael and other psychologists, psychiatrists, so that we can improve the situation with regards to what's on offer to women in those situations.
Yeah, it's fantastic to have those collaborations, isn't it?